Hi, everyone. Welcome to today's Pediatric Diabetes Network webinar entitled Bridging the Gap in Diabetes Care Transitions, Research Findings, and an Opportunity to Join the Bridge T1D Study. So we're just going to give a few minutes for people to come in and get settled. I'm going to try out our chat. If you want to let people know, if you feel like sharing where you are today, where you're coming from. We'll give everyone one more minute. You need someone to test the chat. Yay. Hi. Thanks. Yeah, lots of snow. Seems like everywhere. Okay, well, let's get started and people will trickle in. We start our webinars and meetings with a land acknowledgement. So I would like to begin by acknowledging my sincere gratitude for the opportunity to work and live on this beautiful land that has been stewarded by First Nations since the beginning of time. This land on which PCMCH operates is the traditional territory of the Haudenosaunee, Wendat, and Anishinaabe peoples. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 with the Mississaugas of the Credit. Toronto is now home to Indigenous peoples from across Turtle Island. PCMCH recognizes that Indigenous practices of health and well-being have been in place in this territory since time began and are maintained to this day. We are committed to honoring and improving our knowledge on these practices. We recognize the harms and mistakes of the past, and we may take meaningful steps toward reconciliation by building and improving relationships with First Nations, Inuit, and Métis peoples. As some of my work is in population health, which is fundamentally concerned with early intervention, equity, and the social determinants of health across the lifespan, I would like to share a link to a video that spoke to me and my work. The video is from a First Nations perspective, one that I feel is relevant to all of us in our work, particularly in our support of children and families and building or rebuilding healthy children, families, and communities. Gwen Phillips from the First Nations Health Authority in BC talks about how we as nations, as families, and as communities nurture healthy children, healthy families, and healthy communities. She talks about having a sense of vibrancy and what that means. She shares that an elder had told her that vibrancy is when our children have a sparkle in their eye, and talks about what that means. To have a sense of belonging, a sense of love, and sense of safety. So I believe I've shared this once before, but I'm going to share it in our chat with everyone today. It is called The Social Determinants of Health from a First Nation Perspective. So before we begin, before I introduce and hand it over to our presenters, a few housekeeping items. You'll be able to post questions in the Q&A function on Zoom or use the raise your hand function. All participants are automatically muted, but when you raise your hand, we can unmute you to ask your question. And we'll aim to save about 10 minutes at the end for Q&A and discussion. All right, so some introductions. I would like to introduce the presenters for today. Dr. Rayzel Shulman is a pediatric endocrinologist at the Hospital for Sick Children and a scientist in the Child Health Evaluative Sciences program at the Sick Kids Research Institute. Her research program is focused on developing and evaluating health services interventions to improve health outcomes and the quality of care for youth living with diabetes. An area of focus is transition to adult care. Dr. Ian Zenlea is a pediatric endocrinologist, clinician scientist, and the division head and medical director of children's health at Trillium Health Partners and the Institute for Better Health. He holds an academic appointment in the Temerty Faculty of Medicine at the University of Toronto. At Trillium Health Partners, Dr. Zenlea leads the Family and Child Health Initiative, a community-based participatory research program that co-designs, co-implements, and co-evaluates services, interventions, and programs in partnership with community members. His work focuses on improving the health and well-being of children and families in the Peel region, across Ontario, and nationally. Outside of his professional roles, Dr. Zenlea is a father of 3 boys and enjoys skiing, golf, traveling, and science fiction. Dr. Nicola McCleary is an early career implementation scientist in the Child Health Evaluative Sciences program at SickKids Research Institute. Her research program uses behavior change approaches to improve the uptake of evidence in healthcare. She has over a decade of experience in implementation science, working to advance the evidence base for effective implementation strategies and developing theory and methods in the field. She has led studies to elucidate barriers to and enablers of change in healthcare contexts and to investigate the mechanisms of action through which implementation interventions operate to achieve intended impacts. She has expertise in conducting process evaluations alongside randomized controlled trials and will co-lead the process evaluation work. Welcome to you all. Thank you very much for presenting today, and I'll hand it over to you.
Okay, so the objectives for today we're going to briefly review some of the transition challenges that I know everyone here is very familiar with. I'm then going to quickly review some of the results that we have from our previous transition study that some of the PDEPs were involved with, called Bridging the Gap. And then the bulk of the time we're going to spend on introducing this new transition study that we're leading called Bridge T1D. So by means of just brief background, so emerging adulthood is the time in life from approximately age 18 to 24, during which people are undergoing many changes in different aspects of their lives. And there's often a mismatch between their developmental maturity and the expectations that are placed on emerging adults in various spheres of their lives. So there's lots of changing relationships between peers and caregivers and parents. There's new economic demands. People are moving in education from secondary school to post-secondary school or to employment, and there's just more responsibility overall in life. And so there are these competing priorities increase the challenges of daily diabetes self-care, and probably explain at least a part of the observation that diabetes management is really poorest in this age group. So this is a slide that's probably familiar to many people. It's data from the US Pediatric Type 1 Diabetes Registry that includes data on almost 1,600 individuals living with type 1 diabetes. And this graph is showing hemoglobin A1C on the vertical axis across the age of the lifespan on the horizontal axis. And what we can see here is that hemoglobin A1C, or glycemic management, is really at its poorest around the age when people are getting ready to transfer to adult care. The good news is that it does improve in the 20s, but we know that this period is people are often very vulnerable to also the risk of increased risk of adverse diabetes outcome, like diabetic ketoacidosis or DKA and hypoglycemia. And also in having gaps in their care. So there was a study done by Garvey in the US that 2 different studies actually that showed that approximately 20 to 30% of individuals had more than 6 months of a gap between their last pediatric and their first diabetes visit. Also some work done in Ontario by Miranda Nakla and Capellan et al. In Germany found that the rates of DKA and severe hypoglycemia are higher in the time immediately after transfer to adult care. And in Ontario, we found using administrative data that having a gap in diabetes care of more than 12 months and no primary care during transition age was also associated with an increased risk of DKA in early adulthood. So there have been a number of both diabetes specific and also just chronic disease in general transition interventions that have been tried. A systematic review tried to bring all these together to understand what are the key components of transition interventions or program that are most effective at improving outcomes around the time of transition. And they looked at this particular systematic review included about 18 studies and found a lot of variation in the types of programs that were studied. So some had transition coordinators, others had specific transition clinics, some had group education sessions. And in the studies that had a control group, which was only 4, they didn't find any difference in hemoglobin A1C 12 at 12 months after the start of the intervention. They looked at a number of other secondary outcomes like clinic attendance, severe hypoglycemia, and DKA, and really concluded that the active ingredients of effective transition programs are just really not established. And there's probably a lot of variation in the clinic context and in the populations that were studied. So just to review some of the findings, and some people may have already seen these, just some of the summary of the results of our Bridging the Gap study that was conducted in 2009 to 2021. And we tested whether an audit and feedback-based intervention improved diabetes management in the year after transfer to adult care. And we did this in cooperation with 5 of the PDEPs in the PDN. This was our team. And just for the interest of time, I'm not going to read all of the names, but some of the people are on the call today. And so just to summarize really what we did was that each clinic who was involved chose a quality improvement initiative that was guided by a GOT transition framework. And I'm just going to skip ahead to the next slide to show what that is. So GOT transition has 6 core elements, and it's an evidence-based framework to support transition from pediatric to adult healthcare in general. It's not diabetes specific. Each of these core elements has tool sets associated with it, and there's measurement and evaluation tools as part of this program. Each of the clinics then chose a quality improvement initiative based on this. We also provided clinics with feedback reports about the activities that youth reported were important to them versus which ones were actually completed. And we found that the intervention improved glycemic management and also prompted adaptation of these quality improvement initiatives. And many of the clinics made adaptations and changes to their initiative as the study went through, which was part of what we were encouraging people to do. We also found or identified that there were gaps in transition care. So, for example, 67% of youth said that it was important to them to meet their new adult provider before they transferred, but only 11 reported that it happened. Likewise, 90% wanted to discuss how to obtain and pay for diabetes supplies, and only 32 reported that that happened. We also did a process evaluation. So interviews and focus groups with diabetes clinic team members that participated. And team members reported that there were positives, challenges, and impacts of participating in this study. People said that they appreciated the flexible and site-specific approach to the quality improvement initiatives, and the feedback reports were helpful. This study was conducted during the COVID-19 pandemic, which people reported impacted care provision and also the implementation of the study. People reported that participation in this study did lead to transition care practice changes and fostered opportunities for them to collaborate with others in the network. So what did we learn from this, and where are we going from here? What's next? So, I think the design of the Bridging the Gap study was not a controlled trial. So we do want to use more rigorous research methods in our next trial. We also wanted to better engage youth and also adult diabetes professionals, as well as community partners. We also wanted to capitalize on this momentum and enthusiasm that we heard from the people that participated, the diabetes team members. We also now, because we have this new Ontario Pediatric Diabetes Registry that's hosted at Bourne, we want to leverage data from this new registry. So that brings us to this new study that we're launching called Bridge T1D, which is an acronym for Building Readiness and Independence During the Guided and Youth Engaged Transition to Adult Type 1 Diabetes Care. And you've already been introduced to myself and Ian and Nicola, who are co-principal investigators. Noah Iver's another principal investigator who's not here today, I don't think. Sorry, Noah, if you've just joined. We have two incredible youth partners, Alina Siddiqui and Ethan Parik, and I think Ethan's on the call today. And our research staff, Michaela Sonnenberg at Sick Kids and Sarah Abdullah and Hamna Khan from Trillium Health Partners. We've got knowledge users from the Pediatric Diabetes Network, from Born Registry, Elizabeth Morrow from CPS to help with knowledge mobilization. And we're partnering with a number of community youth organizations, both diabetes specific and otherwise. So just a little bit more background about this particular study. So from Bridging the Gap and other studies in the literature, we know that audit and feedback is a quality improvement approach that works best if healthcare providers use the feedback to develop sustainable plans for improvement. And we also learned from Bridging the Gap that audit and feedback, or ANF, is best paired with peer discussion and action planning through a community of practice. So communities of practice are groups of people who share a common goal and who want to improve their knowledge and practice through interacting and learning together. And they are often used to share resources, to provide training, and to build practice-based social networks. And the other thing we learn from Bridging the Gap is that youth often feel like their priorities are not always reflected in transition care. So that brings us to the study aims of Bridge T1D, which are to understand if including youth in a community practice together with audit and feedback improves transition outcomes. And briefly, there's three aims. The first aim is to co-design an ANF-based youth engaged community practice, which Ian will tell you more about. The second aim is to test whether the intervention improves readiness to transition in a cluster randomized controlled trial in PDN sites. And then third, to understand how intervention components were implemented, mechanisms of change, and the influence of contextual factors that Nicola will tell you about. So Ian, get ready. I'm going to hand it over to you to talk more about the co-design. You can just let me know when you want me to advance the slides.
Perfect. Thanks, Rayzel. Good transition too to tell me to get ready. Can you guys hear me? It looks like I'm frozen. Can you hear me? Okay,
Yeah.
I'm frozen. Okay. Awesome. So we're really excited to be coming to you all today with this new study that Rayzel has described. So our team, the Family and Child Health Initiative at Trillium Health Partners, will be leading the first aim of the study, which is to co-design the intervention. So this youth community of practice, youth-led community of practice, it doesn't exist. It's not off the shelf. And so we are actually starting to build this from scratch, leveraging some of the findings from the prior studies that Rayzel had spoken to. So the objectives of this co-design work, which we want to engage all of you in, and so after this meeting, we're going to have an expression of interest distributed for some of you to join, hopefully to want to volunteer and join some of our activities, including our project advisory board, which I'll speak to in a moment. So the objectives of this first phase are really fourfold. The first is to engage youth with type 1 diabetes, healthcare professionals like yourselves, caregivers and researchers through a project advisory board, and as youth peer researchers to support all research activities. So the projects that we typically lead through the Institute for Better Health and our Family and Child Health Initiative team include a governing body that contributes to steering the research activities, and that is the project advisory board. So that's the integrated level of lived experience and professional experience coming together to guide the conduct of a project. So provide input on methodology, outcomes, outputs, the whole process really as the study unfolds. So we see this project advisory board as playing a key role in all aims of this study. So not just the co-design, but through the implementation and evaluation phases. Some of you have been members of project advisory boards and some work that our team has also supported. One is the Capacity Registry Project, and I think members of this audience are also part of that advisory board. It's a great opportunity to take a hands-on approach to some of this work. And really be a bit as high touch or low touch as you might want to be. One of the other exciting features of this project is that we actually want to hire people, so youth with lived experience, to join the project team as peer researchers. So these people, and if Ethan is part of this call, he actually has been a peer researcher with our team for several years now, started volunteering with us as a high school student, and now as an undergraduate medical student is a member of our team. Hi, Ethan, he said in the chat. And so we hire people with lived experience. The only experience they need to have is lived experience. They get hired into our Institute for Better Health. They join our research team, and we build capacity for methodological approaches or techniques, whether it's mixed methods, quantitative, qualitative. They're really paid, employed members of the research team. And so we'll be bringing on youth as peer co-researchers or peer research assistants. We've used the language with many of our projects. So that's another fundamental core component that makes this youth-led and youth engaged. We'll be bringing together people, youth specifically, with type 1 diabetes, caregivers, and researchers through knowledge exchange events to actually prioritize transition-related elements, reflecting on some of the research that we've done previously to create some of the foundational core curriculum elements of what will be included in this community of practice. We're going to co-design the tools. We're going to come up with some pitch ideas through a really exciting hackathon approach. For some of you who've had experience working in hackathons, it's a really engaging, really hands-on approach to creating a prototype solution. So we go from a concept or problem statement through a design process that's quite structured and mentored and has some panel judges. And we pitch ideas. Teams will pitch ideas for a prototype solution. And now those ideas that are the most successful will be carried forward into the next phase, which is actually creating the toolkit, the Youth COP toolkit for implementation. So this slide just delineates that process and more of a, I guess, a longitudinal approach and more of a timeline. So again, starts with recruiting the youth, caregivers, healthcare professionals, researchers, identifying priorities through knowledge exchange events, which include some creative future workshop methodology, designing prototypes through a hackathon, and then actually having finalized materials, this toolkit for this actual program for the community of practice. And when we take this approach, you're going to see elements of community-based participatory research, which is that community-engaged, community-led component, and the human-centered design process. So we bring those two techniques, those approaches together for this first aim of this project. Thanks, Rayzel, for advancing me. I think I'm turning it over now back to one of you.
Back to me.
Thanks,
Thanks,
Rayzel.
Ian. Okay, so for the trial, we're going to invite all 35 PEDAPs. Everybody's eligible to participate, and then we're going to randomize each of the PEDAPs to either the control arm or the intervention arm. Both arms will receive this audit and feedback intervention, which I'll explain a little bit more in the next slide. And the intervention arm will also participate in this transition community of practice that will be co-designed in the phase 1 that was just described. And the intervention will run over 24 months. In the last year of the intervention, we will start to collect some outcome data. And all the data from this study is going to come from the PDR, the Pediatric Diabetes Registry, housed at Bourne. So we will not be collecting any patient data directly from the PEDAP. So it makes things a little bit easier to conduct for that reason. And we'll be collecting information from the PDR on adolescents who are aged 15 to 18, who are followed at all of the PEDAPs. So just a bit more about what this audit and feedback is going to look like. So the data will come from, as I said, the PDR and also linked to provincial administrative data at ICES. And we'll provide, again, this is all going to be confirmed during the co-design process, but approximately 4 reports every 6 months during the study. The reports will include different outcomes related to transition, which will be confirmed and there'll be input put into that, what are the outcomes to be included in the reports during the co-design. But the idea is that PEDAPs diabetes teams will reflect on these reports, consider whether they want to make any changes to their processes of transition care, and this should ultimately improve transition readiness, which is the main outcome of the trial, which I'll also talk a little bit more about. And then for the intervention arm only, diabetes team members will be invited to participate in this youth-engaged community of practice. And the details of what that's going to look like will all happen in the co-design. So how often the sessions will run, what topics will be discussed, the length, the format, that's all going to be confirmed in the co-design. As Ian said, again, co-design will be training materials for the people who are facilitating and co-facilitating the sessions. What we're aiming to do is to recruit youth, both adolescents and young adults, and train them using this material to co-facilitate these sessions. We're going to make sure that the attendance at each of the sessions is balanced between youth and healthcare providers to make sure that there's balanced representation to prevent power imbalances and make sure that you feel comfortable. Because the sessions made for that reason have to be smaller, we do plan to repeat topics to make sure that as many healthcare professionals can attend as they want. And we'll also be recording and summarizing these sessions. So diabetes team members who aren't able to attend these sessions live will also have the benefit of reviewing what was discussed. And included also in these sessions will be, as I said, the youth, pediatric, and also we'll invite adult diabetes healthcare professionals from the clinics to whom the PDEPs often refer patients for adult care. And what we hypothesize is that these participating in this community, these communities of practice, or this community of practice, will support providers by sharing and also leading to improvement of the quality of transition care that they provide, and with the involvement of the youth to ensure that youth priorities are addressed. So the outcomes of the trial, so the primary outcome is readiness to transition, which we're going to be measuring with a validated patient-reported outcome tool. And I'm going to just flip to the next slide to show you what that is. So the READY tool was developed by experts at Seattle Children's and Cincinnati Children's Hospitals in the US, and it assesses adolescents and young adults' self-reported confidence about type 1 diabetes specific health knowledge and skills. So you can see here that there are 4 domains included in the READY tool, and this is what it looks like. This is a paper version, but it can also be delivered electronically. And so what this shows you is these are the skills, specific skills. And then there's a Likert scale where participants will report their level of confidence to be able to complete each of these activities. And so the results from this tool can help clinicians to identify what are priority topics for a young person. And they can also follow like changes in people's responses over time to see if they're increasingly ready for transition. We're going to be using the newest version of Ready, which is the 2.0, and it includes 36 items in total. And this will be collected through the PDR. So PDEPs don't have to independently implement this in their clinics. And I know some PDEPs are already collecting this. So the primary outcome for the study will be the confidence in the knowledge domain of this tool or a questionnaire. Secondary outcomes will include the other domains on the Ready. We'll also have different measures of glycemia and some post-transfer outcomes, including adult clinic visits and diabetes-related ED visits and hospitalizations. Okay, so I think we're now moving into the process evaluation. So Nicola, I'm going to hand this over to you for this section.
Sounds good. Thanks, Rayzel. Could you jump to the next slide? Thank you. So we're planning a process evaluation that would be conducted alongside the trial. So I just have a few slides that just give some information about what we're hoping to achieve with that component of the study. So we'll do this alongside the trial in both of the trial groups. So the group that received just the audit and feedback, and also the group that will receive the audit and feedback, as well as the community of the opportunity to participate in the community of practice. So a process evaluation is just a type of study which really tries to understand how an initiative like this actually plays out in practice. So we look at how it's implemented, and we're trying to understand sort of how it works in the specific contexts that it's implemented in. So we're trying to understand how it functions. We look at implementation mechanisms as well as some contextual factors as well. And this just really helps us to have a bit more of a fulsome understanding of how and why any effects that we find occur, so that we can then replicate them or potentially improve them in the future. Next slide, please. So in terms of our objectives, got a few objectives for the process evaluation. So we want to understand how these different intervention components, so the audit and feedback and the community of practice, are actually implemented. And we want to explore the potential mechanisms of change. So What that means is basically the factors that influence what happens in clinical practice that we are actually addressing with these interventions. We want to identify any interacting contextual factors that might be impacting effectiveness, as well as, really importantly, to assess the impact of participating in the community of practice on those youth participants who will be involved in that. Next slide, please. So just some kind of very high level details on the methods that we'll plan to use. So we'll be using analytics data on the audit and feedback delivery and receipt. So for example, that helps us confirm that the reports are actually delivered and received in the way that we expect them to be. We'll do observations of the community of practice sessions to help with assessing alignment with the design plans in terms of the structure and the content, for example. We'll have a questionnaire component for healthcare professional participants to assess those proposed mechanisms that I mentioned, so those factors that we're trying to target to support any practice changes that you might decide on. So just as a really quick example of that, we expect that the taking part in the community of practice will provide supports around knowledge of the unique priorities of youth and also support effective communication with youth about their priorities. So these are the kinds of things that we would be asking about in that questionnaire. We also plan to do interviews with healthcare professionals just to further explore those kinds of factors and find out about any practice changes implemented and anything that might be impacting engagement with this initiative. And finally, we're planning focus groups with those youth community of practice participants to really help us explore the factors that are hindered or facilitated their engagement and the impacts on them in terms of their personal growth and their development. I think that's all for me.
Thanks, Nicola. Ian, do you want to talk about the opportunities for engagement for co-design? Oh, Ian is frozen. Okay. Okay, so I can take it, or actually, did you, Hamna or Sarah, do you guys want to do this? If not, I can do it. Just let me know. No? Okay. Ian, if you unfreeze, just unmute and let me know. So for the co-design, I think there are a number of different opportunities for healthcare professionals and also for youth to get involved. So Ian talked a little bit already about participation in the PAB or the Project Advisory Board, and the recruitment flyers for that have already gone out. So if you haven't seen one, then we can certainly send that out. And we're looking for youth, healthcare professionals, and also community organizations to participate in that. And then, oh, I just heard someone joining. I don't know, Ian, are you there? No?
Trying to be, but I'm not going, so let me sign out. Keep going.
Hold on, can you just mute your computer? Because now we're getting an echo, but we could hear you on your phone, I think. Okay, I'm just going to keep going. And if you, okay, so then we're also going to be recruiting to participate in some of the knowledge exchange events for the co-design. And again, the same people we're looking for youth healthcare professionals as well. And we're going to start recruiting for that in the spring. So you can keep your eyes open for that. And then there's going to be a number of different events. So there's knowledge exchange events, and then there's the hackathon that Ian also spoke about, which will happen a little bit later. So probably closer to the end of the year. And then the last thing is to develop those training materials. And that will be sort of early in 2027. So this is just a bit of a timeline so people understand how things are going to flow. So we're currently now recruiting for participation in the Project Advisory Board. And then the next thing will be in the spring, recruitment for the co-design, both youth and professionals. And then starting early in January, I think Ian's back.
I'm back, but
You're
I think
back.
you did a great job.
Do you want me to go back? How did I do? Did
No,
I
I think
miss
that was
anything?
great. I heard most of it. I think that was great.
Okay. Do you want to
I
add
think that
anything?
I would just say that we're going to follow up. It looks like there's two of me now, so who knows? But I'm not echoing. We're going to follow up with an EOI, so an expression of interest that'll be circulated to all the members of the PDN to express their interest in joining our project advisory board. That's priority one, is convening that advisory board. And we're aiming to have our first meeting sometime end of March, early April, so we can really dive into these co-design activities that we have planned. Also, there will be an opportunity again to join the specific co-design activities like Rayzel was speaking to. So your project advisory board involvement is not just it. That's not the only opportunity. As you can see from how we're approaching the co-design, there will be many of these opportunities. So everything from the workshops where we're planning and prioritizing, identifying an ideal future state, through this future workshop method, which will be pretty structured, to the hackathons and so on. We'll make sure that we are advertising these opportunities throughout our AIM 1. The first priority is the convening of the project advisory board. And I think we've had some expression of interest. I know we have actually. I don't know why I said think, because we circulated this opportunity to the members of the project team, so everyone who was named on the grant. And so we've had some people step forward, including people with lived experience. And so we're going to be sending this out to all of you. The project advisory board component, the convening of that does not constitute research, just for people's awareness. We are in the process right now of applying for REB approval for the co-design activities that'll come next. These are pre-planning, so it's the project advisory board is outside of an REB. I'm just saying that because every institution has different policies and procedures related to advertisement of opportunities to engage in project-based work. We know that this can be a bit of a tricky thing to navigate. So if anyone has any questions or would like to share some of these opportunities with your clinical teams or with your patients and you're not really sure there are specific institutional requirements, we will work with you. So just reach out to me and we'll try to field your questions and help problem solve along the way. But this part, just to be very clear, the project advisory board itself, there's no informed consent process. This does not constitute human subjects research. That being said, we will make it very clear that there will be a bit of a terms of reference for this group, and we'll come up with those shared principles about how we're going to interact with each other as this project advisory board moves. And we haven't in those terms of reference yet established for what duration you would like to be involved. I think we'll have those conversations with everybody individually. And this project itself is a very long project. So our expectation isn't that people who enroll, who want to sign up for the project advisory board are with us for the whole duration of this project. So we'll work with you all. And if we have to renew membership, we'll do that periodically as well. So just stay tuned for that opportunity. That'll be hopefully hitting your inbox with Jennifer's support. And then also Hamna or Sarah, who unfortunately, Rayzel, because they're not presenters, they couldn't speak when you turned. It's fine. But they were ready to go, but they couldn't, and I was frozen. So you did a great job. They will drop it in the chat, just the link to the EOI for people if you want to click on it during this meeting. Okay, I think I'm finished. Thanks, Rayzel.
Perfect. So, sorry, can you hear me? I can't see if, okay, amazing. Okay, so just this is happening far in advance, but we will be applying for REB approval for the trial and are hoping to start recruitment for enrolling the PDAPs in the trial early next year, so January to March 2027. And then we'll be recruiting people to participate in the community of practice, and the intervention will run from July 2027 through June 2029. So in preparation for submitting our REB application for the trial, we in the coming weeks will be distributing surveys through the PDN, so it'll come from the PDN to each of the PDAPs, just with some basic questions about research ethics board approvals at each of your sites, so that we can understand and figure out what the best way is to get REV approval for all 35 sites, which can be a bit of an undertaking. So just keep your eyes out for that, and please fill out the surveys when you receive them. Like I said, we are hoping to be able to include all sites to participate, and if there's any questions or barriers or things, just please reach out to us so that we can try to resolve anything. And then just our contact, and we're gonna I think Allison and or Jennifer are going to circulate the slides. So our emails are all here if you have questions. And then the research team at large, we've got bios here. We didn't have time to introduce everybody, but they're all there. So so take a look at those as well. So I think I'm going to stop sharing now and open things up to any questions or comments, suggestions.
I'll answer one question that's in the chat that I was trying to type an answer to, Rayzel, and it's from Kelly about whether the project advisory board has specific meeting times already established. The answer to that is no. What we'll do is we will schedule the first meeting, which is really the project advisory board kickoff meeting, and then we ask the group collectively what might work best for their schedules, and we try to accommodate people's varying schedules. Generally, we've found that for people who are clinicians working, daytime hours, and for members with lived experience who may have less flexibility, that meeting times in the late afternoon or early evening tend to work best. But again, we'll establish those meeting times when we kick off the first project advisory board meeting, which will likely also be in the late afternoon, early evening. So more to come from communication with our team. And we make sure that we send out meeting minutes and so on for people who've missed meetings so that people can stay up to date, and we're happy to connect with people asynchronously as well. Okay, Rayzel, question about the access. Ready 2.0, will the PDEPs have access to this and then enter into PDR Biz?
Yeah, so it's a great question. Actually, thank you for bringing it up because I meant to mention this. So we are working collaboratively with Born and PDR as part of this study. Part of the funding is going to support collection of Ready 2.0 into the biz. And so that's part of the work that we're doing. Like parallel to when Ian and his team are doing the co-design, we're working with Born for them to build the infrastructure to be able to collect this at all of the PDEPs. So you will hear more about this. And as they've been flexible about data collection for all the other variables in the registry, there will be flexibility too about how to collect Ready 2.0. So centers that are able to do this like electronically, and if it goes directly into your EMR, you'll have an option for automatic upload. Centers who are on manual will have the option to do it more in a manual way. So they're going to work with everybody to try to facilitate everybody to be able to collect this. So I think that's what you meant by access to. And then the results certainly will then be available back to you through PDR mechanisms, however that ends up being, whether it's a dashboard or reports and things like that.
And I'll just add that what's exciting about this is the first patient-reported outcome measure that'll be collected in the biz, which is awesome, right? In the PDR, it's the first of many, we hope, and it's pretty cool to see this being designed. And we're working really closely with the Born team about like specifically looking at clinical workflows to enable the collection of this information, recognizing that sites will likely be providing the tool for completion paper-based, and then maybe we'll have manual data entry, but we're being really intentional working with Born around what those workflows might look like. And it's a really exciting opportunity. And the first, we're hopeful of other patient-reported outcome or experience measures that'll be collected in the PDR.
That was excellent. Thank you so much. Are there any other questions for the team? I love that your study begins with co-design. And there are a lot of opportunities for engagement. And so I think you kind of touched on this, Ian, but for the people, is there there are many opportunities at various stages to participate. Is there any minimum expectation of, say, the researchers or people with lived living experience?
I would say that if you are going to be, that we would want you, if there's a specific, each one is staged, right? So we presented the different activities, and they're consecutive, and they do build on findings from the prior. So if someone is interested in participating and they're registered, we don't need them to stay necessarily for the whole thing, although they'll have opportunity to continue to participate throughout, which is really exciting. We would want them to participate for the entirety of that singular activity, though. So if you're going to start with a hackathon, you should stay on the team and see that through. Similarly, before that, if you're starting with this future workshop method that we're using, where we're envisioning, like looking at current state and really envisioning this ideal future state, that you're staying for the entirety of that specific activity, if that makes sense. And then because they're building, somebody may want to be participating throughout, which would be great, because then they've got that longitudinal experience and they've been part of it. We'll make that very clear also in how we are sending out our expression of interest. And in every expression of interest that's completed, we do a call. So we contact that person, and we just have a conversation with them about, why they're interested, whether this, is this the right opportunity? Are there other opportunities that they may want to participate in? Sometimes we get a lot of interest and we have to add people to a wait list. We try to create, as much as we can, a diversity of experiences. And so we have a bit of approach to that, more of a purposive sampling approach using research language. And so even if people don't maybe make it into that activity, we might waitlist you, or waitlist you for that activity if people don't, we don't have the right number of participants, or we'll ask you specifically, can we contact you for other opportunities? And then you'll be the first ones we call. So we try to give everyone an opportunity who is interested.
And for the youth participants in both the co-design and in the community practice, we have remuneration built into the study for them.
That's great. These are helpful details for people, I think. And I guess out of curiosity again, the methods you had talked about, Nicola, that you have groups of focus group, the youth involved in focus groups. Will they also be involved in the analysis of your findings of the data?
Oh, I'm back. Yeah, that's a really good question. I don't think we have got to talk much in detail about that, but certainly in projects I've been involved in before, we've involved lived experience advisors in, looking at themes that come from data, and that, that doesn't have to just be like from the youth focus groups. That can be from what comes from like the interviews with healthcare professionals as well. They can sometimes have really good insights into sort of things or aspects, themes in the data that that they might pick up in a different way from the researcher angle, for example. So certainly there'll be opportunities for them to be involved. Of course, not just in the analysis, but like how we collect that data. So like our interview and focus group guides and how we structure the questions and all those kinds of pieces. So yeah, for sure that will be something that we embed in there once we get to specify those processes in a bit more detail.
Yeah, and just so building on what Nicola just said, the project advisory board is a great space for that to happen too, as we build in that's the structure, Jennifer, where some of that interpretation will happen. We do also have, as members of our team, like Rayzel spoke to, we do have 2 youth who are co-PIs on the project. So they're, as part of the project team, they will also have the opportunity to participate in the analysis and interpretation of the findings. So there'll be multi-level opportunities to bring in that youth perspective and that youth interpretation, given that this is youth-led, youth engaged, and it's really youth who will be teaching us and training us as healthcare providers how to enhance their transition experiences. So that is a critical, important, and a core function of this project.
Excellent.
Is this a different question from, I think Kelly had a follow-up question, bi-monthly as in twice a month or as in every 2 months again?
Every 2 months. And it may happen, it depends. It depends on how the pace of the project is going. Generally, we say bi-monthly, meaning every 2 months, not twice a month. There will be some asynchronous work that may be happening between meetings, or if there's something that urgent that comes up, we may have to have a meeting like, like in a month later. It really depends on the cadence of the project and how we're working. And we have those conversations as an advisory board once it's convened. And we don't want to overburden people by any means with too many meetings. And so sometimes we drop a meeting if there's not much happening, and we'll send in, an email update and then engage people again asynchronously. But in general, just to set people's expectations about time commitment, these meetings tend to be 1 hour. Sometimes they're 2, and we're saying likely not more often than every other month. I hope that answers the question.
And we'll be sharing your contact information so that people can reach out to you with additional questions, and so you can give them details they need. Are there any other questions, team? This is very exciting work, and we're really happy. PCMCH is very happy to be involved as a knowledge user, and to disseminate, the information as broadly as we can, so that the PDEPs can be involved in this really exciting work.
Thanks so much for having us and giving us the opportunity.
Yeah. So thank you to all of our presenters, Rayzel, Ian, and Nicola. Thank you so much. We'll be giving out, there'll be a survey after we finish, and we'll hopefully see everyone at the next PDN webinar. Thanks so much, everyone, for joining today. Bye now.